interesting topic today. We will expect a lot from today's discussion. And just to let you know, people from Tanzania and Kenya are also learning a lot from this partnership. And so during the discussion, during the panel discussions, remember that we are all learning from this great initiative between Toweza and the government of Uganda. Yeah, so as you know, Toweza is a governance-focused organization, and we use research data to create and facilitate conversations among stakeholders. And we work in Uganda, Kenya, and Tanzania. We are inspired by the idea of getting citizen voices and experiences into decision-making spaces so that interventions respond to citizen concerns. And today we are having this last of our 6 webinars in the series of COVID-19 focusing, and the topic of today in maternal health. And we thank the Ministry of Health for this collaboration and commitment to mobilize and attend each of the webinars we have held. And we are grateful to the panel of experts, the moderator, and the journalists who are always present at the live event at Hotel Africana and those online. Also, we appreciate the health experts that join these sessions online to share their knowledge. And we do hope these sessions continue to enlighten us and give us more hope for better. Yeah, we really wish you all the best of luck. Enjoy the session. That's being said, thank you, and allow me to return the microphone to you, moderator. Thank you.
Much, Anastasia, for those welcome remarks. That said, I will
Marie also is going to appear via Zoom to give us the Sauti za Wananchi findings on women and health. Mali, over to you.
Good morning, moderator. Marina Nyanzi, and I work with Toweza East Africa as the Senior Program Officer for Sauti za Wananchi, and I sit in the Uganda office. For today's presentation, because we value data, we value research, we have also partnered together with the USAID Social Behavior Change Activity, and I'll be presenting these findings together with Judith Nalukwago, who is a senior advisor, monitoring, evaluation, and learning at the USAID Social Behavior Change Activity. So I'll start by sharing my screen. Okay, great. So today's presentation okay, fine. Thank you so much. So there is some echo from your side. I don't know. Okay, I think I can start. So once again, I'm Marina Nyanzi, and I'm the Senior Program Officer for Sauti za Wananchi, and I sit at Toweza in Uganda. Today's presentation, which is titled Women and Health, I've also been joined by USAID Social Behavior Change Activity. It's a program that is under the Johns Hopkins University Center for Communication Programs. And I'll be joined by Judith Nalukwago, who is the Senior Advisor, Monitoring, Evaluation, and Learning. So we'll do this presentation together. To start us off, the presentation is titled Women and Health, and we'll be sharing a perspective of the citizens' experiences in the health sector in Uganda, but for our literature review, we shall go beyond just Uganda. Again, I won't repeat so much of the objective. That is why we do this. But in summary, we share data because we want the citizens' views to also feature in the decision-making spaces, and also be able to inform some of the policies and also implementation of different programs. For our Sauti za Wananchi methodology, also briefly in the interest of time, we have a national panel of 2,000 respondents across the entire country. And in selecting this sample, we work together with the Uganda Bureau of Statistics. And we also secured research permits all the way to the Uganda, to UNCST. So the data that we share here has a confidence interval of 95%. More of this can be found on our website. Can be found on our website so that you can get to know more about the Sauti za Wananchi program. Like I mentioned, we'll share the key findings and we'll start with the literature review, then feedback from the Sauti za Wananchi respondents, and then we will conclude. At this point, I want to invite Judith Nalukwago to go through the literature review. I will help to control the slides on this end. Judith, over to you.
Yeah, thank you very much, Marie. So just to give us a bit of background, under risk, the Ministry of Health Risk Communication Pillar, USAID Social and Behavior Change Activity supported in doing a literature review on the effects of COVID-19 on COVID-19 on the different layers of the populace. But for this presentation, like Marie has mentioned, the focus is really going to be on mental health, on maternal health, sorry. So we start off with the findings that we saw in the literature under maternal health. We found that overcrowded hospitals have caused reluctance to seek care. And here it showed that pregnant women are unable to be hospitalized due to overcrowding. The literature also revealed that pregnant women report higher levels of anxiety, stress, and depression. And as such, pregnant women report keeping fewer appointments due to stress. They have the fear of contracting and transferring COVID-19 to one's child. And there's also limited mobility during the lockdowns. And because of this, the literature also revealed that there's a rise in stillbirth, maternal mortality, and infant mortality. Next slide. So moving on, we also found in the literature under mental health of the pandemic. And the most interesting bit is that women, students, and individuals under 40 are the most vulnerable populations for experiencing depressive symptoms. And why the women? The women are at higher risk due to their higher involvement in workforces that may be more affected by COVID-19, such as the retail, services, and also healthcare. And the students are more vulnerable due to the school closures, potential learning loss, and also the reduced social activity, which they in most cases engage in usually. Then for the individuals under 40, and these include the women and the students, these are vulnerable due to the potential of higher caregiving responsibilities and the frequent social media use. So rounding all this up, we realize from the literature that there's usually limited knowledge about issues of mental health. And then there is limited mental health care services. Just back 1 minute, Marie, back to the last slide. Yeah, limited mental health care services. And also most interestingly, the increased social media use, the addiction, and also the messages that come through social media sometimes lead to depression and stress. Next. So we also looked at gender-based violence in the literature, and what we saw is that there were increasing reports of domestic violence against women. An example of Kenya, we found that the women and children, gender-based violence increased among women and children by 4% and 13% respectively. And we also found in the literature that psychological violence was most prevalent than the physical violence. And we also saw that 78% of the cases of women who are experiencing violence for the first time, and that was. So from the literature, we also realized that the majority of women who were experiencing violence did not report the violence, and this gender-based violence was also linked to the social norms. The attitude addressing the gender-based violence was linked to the social norms and the attitudes towards the violence against women. When women believed that the people around them in the society were condemning gender-based violence, there were higher chances for them to report the violence. But if they felt that they don't have support of the people around them, they would keep quiet about the violence. Next slide, please. So what are some of the approaches that we saw in the literature in terms of addressing maternal and gender-based violence? The literature revealed that some of the approaches like sex education, empowerment activities, and mentorship at safe and support spaces were important in addressing some of the issues under mental health and gender-based violence. Then also media campaigns or online small clips that have messages that relate to maternal health and gender-based violence were key. We also saw that messaging frequently of maternal health information, I've talked about that, and then frequent SMS messages using role models talking about topics under maternal health and gender-based violence, and then multiple interventions aimed at promoting widespread mask wearing or masking, and also sending videos from a respected role model about health behavior. This one is the routine, sending of recorded messages through different platforms, social media platforms, with role models talking about different areas around maternal health and gender-based violence. And then gamification, the quiz style was also effective at compliance, whereby we send out a message about maternal health, and then after some time you send out a question to the people about that information that you shared earlier, and then ask them to respond to that question. Then from their response, you again send out the information again for them to see. That's the quiz style approach. And then the intermittent WhatsApp messaging or messages to debunk the rumors. As the rumors come, or as we see the rumors through the different social media platforms like WhatsApp, like Facebook, we need to have approaches of sending intelligent messages to debunk some of the rumors as when they come.
Thank you, Judith. So now we do the citizen experiences. We don't 3 districts of Kampala, Chotera, and Tororo. So from our findings, we see that when we look at what is the most serious problem facing Ugandans, both male and female say that health is the biggest problem. But we are seeing that slightly more women than men mention this as the most serious problem facing the country. Then when we look at the data that we collected in November last year, we also did see that the citizens say, this was from our national panel, we see that the citizens say that teenage pregnancy and other social problems have increased in their community during the pandemic. And here we were seeing that when we asked what has become worse during this pandemic, we were seeing mentions of physical violence becoming worse. This was mentioned by more than 50%. That is 51%. Then emotional violence was also mentioned by 51%. Then sexual violence was mentioned by 46%. This also speaks to the literature review that has been shared by Judith earlier. Then for the teenage pregnancy, we did see that 79%, that is close to 80%, mentioned that they had observed that teenage pregnancy had become worse in their community. Other situations that they observed that were problematic was the increase in the alcohol consumption or abuse, as well as the drug use and abuse. And when we look at the people who mentioned physical violence and also emotional violence and sexual violence, we had a higher mention from the women compared to the men. And again, we could say that maybe this is because women are really in most cases, they bear the burden of being primary caregiver in the home and also in the community at large. Then when we looked at the data that was collected from our national panel, both in 2018 and 2019, we just wanted to understand when someone goes to a health facility, do they receive treatment for free or they pay for it? And here we looked at 3 categories: the pregnant women, the sick children below 5 years, and then the elderly, that is someone who is over 60 years. And we did see that most pregnant women report receiving free treatment, though a growing number were saying that they have to pay for that, because we saw that 16% mentioned that they were paying for that treatment in 2018, and then this number went up to 28% in 2019. The situation is also slightly similar for the children and also those that are over the age of 60. Then when we look at what the women or the male and female think about the exposure or the risk of being exposed to the coronavirus across the 3 districts of Kampala, Kyotera, and Tororo, we see that women in Kampala feel less exposed than the men to contracting the coronavirus, but we see less of a difference in Kyotera and Tororo. So again, this would probably point us to reflecting on the context in which these women live, that is in Kyotera, Tororo, and also Kampala, because they could be engaged in different economic activities, and this could factor into how we communicate to them during a pandemic in regards to their health-seeking behavior and so on. Then for my second last slide, we also wanted to understand in terms of seeking treatment in case they got sick during this time, in case they got the coronavirus, between the male and female, do they feel confident that they would immediately get treated? And we have seen that both women and men in Kampala and Kyotera lack the confidence that they would get treated quickly if they fall sick. And this is quite different from those that reside in Tororo, who are more confident than the 2. But again, we see that the women in Tororo are more confident that they will get treatment in case they fall sick, in case they contract the coronavirus during these times. So to conclude, from all that we have shared, we see that there is a need for more awareness for women on the available health services during a pandemic. Because if at all someone is not confident about getting treated when they fall sick with coronavirus, this might become a barrier for them to actually go to a health facility and seek treatment. Then again, on the issue of the payment, how many women actually know that they can probably get services at no fee? If at all someone suspects that they will only receive treatment at a fee, then that might become a barrier for them to access services. And more so during a pandemic where they have other fears like contracting the coronavirus. So because of these varying risk perceptions, there is a call for us to understand the context of the women in both the rural and urban locations. And this should then be factored in or reflected in the different communications that target these groups. So at this point, I think it's a pleasure to again know that we have experts in the house who know our maternal health policies and can educate us more on this and what our citizens are entitled to. Once again, thank you so much. All that we have shared today will also be available on our website. Thank you. Over to you, MC.
Very much, Mali, for that presentation. And I'll expect our panelists here to make comments once their time comes to address us on different topics that have been allocated to them. Ladies and gentlemen, without wasting time, I will welcome Honorable Sylvia. You're welcome to this panel, and thank you for honoring our invitation to be part of this discussion on maternal health and reproduction amidst COVID. I'll go to our first panelist, and I'll invite Dr. Richard Mugahi, Assistant Commissioner, Reproductive Health and Infant Health, Ministry of Health, to address us. And maybe we've received findings from Twaweza. You can maybe give us an insight on how we stand as a country on maternal health, what the current situation amidst COVID. Then you address a certain question that keeps coming around: should pregnant women be afraid of continuing to access maternal health services during the current pandemic? And maybe you can enlighten us on what are the current guidelines in place to enable mothers to access these services during this pandemic. Over to you, Doctor.
Thank you so much, moderator. I would also like to join you to welcome my fellow panelists, very senior people under the umbrella of the National Safe Motherhood Experts Committee, as they will be introducing themselves, but I really appreciate their time. I appreciate their commitment. We've been working together on so many things, and they are now here to present to the citizenry about issues of maternal and child health. I also want to appreciate in a special way my former colleague and now Member of Parliament, Honorable Sylvia, for sparing time and being with us in this very critical issue. As we've always said, in maternal and child health, we need everyone. We appreciate you, members of the media, and Twaweza for according us this opportunity to ensure that we share what is being done amidst this pandemic, to share what we think should be done, and how best we can carry on and save the mothers and children or newborns in this country. The issues around maternal and child health in this country, there is quite some progress that was made. But of course, when a pandemic like this one comes in, like COVID, that disorganizes the entire health infrastructure, it also equally affects mothers, it equally affects the newborn and children. So I must accept and mention that there has been disruption in our service delivery in terms of caring for the mothers and the newborns, but this has not been very significant. I had a look at our data. We we look at data, and I'm happy Twawezi is also using data. The number of women seeking antenatal services in the last 6 months has not changed significantly. And the number of women delivering in health facilities has also not changed. We have this information. I looked at it very critically. And to us, this is very positive information, meaning that under our approach of continuity of essential health services that goes down to the service delivery points, our healthcare workers have done a tremendous job. What we see increasing, which actually has come out in the report, are the numbers of perinatal death or children who are dying, young newborns who are dying. That one has really increased. And we have a system at the Ministry of Health that is monitoring these deaths and analyzing them, where they are happening, why they are happening, on a weekly basis. We also have a system that's monitoring maternal death, where they are happening, why they are happening, on a weekly basis. And this has been done to the detail. We know those who are dying because of COVID. We know those who are dying because of other pregnant women who are dying because of other diseases. So we've been able to use this information very well with this expert team to see how we improve on our approaches of handling pregnant women. One of the significant things that we've done over the time is, in the recent past, is we've been able to update our guidelines on management of COVID-19 in pregnancy. At the beginning of this wave, we lost some mothers, inevitably. We lost quite a number of pregnant mothers, and that was very unfortunate. We quickly looked at our data. As I mentioned, we look at this data on a weekly basis. We quickly looked at this data and we are able to find out where the gaps were, and we quickly updated our guidelines. These are due for dissemination, but we've already disseminated some electronically, so that our service providers at the service delivery points are able to have a very guided approach towards such interventions. We know we still have a challenge of maternal death, and with the lockdown, we had an issue of transport. Transportation of mothers was actually an issue, and we also saw that one of the leading causes of maternal death were delays in the communities. There was an obvious delay of mothers accessing care, leaving where they were staying and accessing the healthcare facilities to seek care on time. This could be attributed to the transport system because of the numerous restrictions, but it can also be attributed to community level, family level, decision-making at family level, which takes some time. So many of our people, while they are pregnant or while they are in trouble, they take time to make a decision. And for us in health service delivery, any time you waste, that has an impact on the outcome of the pregnancy and the outcome of the mother, especially if she has COVID-19. So back to the question that you gave me, the question of should pregnant women be scared to attend antenatal care in the current state of the pandemic? The answer is no. The answer is no, and this is supported, well supported, by the fact that we have a health infrastructure that can deliver services to the lowest level, at a sub-county level. Maternity services or antenatal services are offered at the lowest level at the sub-county, and we have trained healthcare workers. The midwives are trained on managing pregnant women with COVID-19, and I did mention that under the continuity of essential health services, we are also supporting them with mentors where they have challenges, and we are supporting the system upwards. We are not managing COVID-19 at health center 3s. If it is, as you all know by now, that COVID-19 is a disease that has different phases. It can present in a mild form, it can present in a moderate form, there's a severe form and a critical form. So the mild cases can be identified at primary healthcare facilities as low as health center 3s. They have testing kits in the country at health center 3s. These are antigen-based testing kits. So a pregnant woman with symptoms can be actually identified. The healthcare workers are trained to triage or to identify pregnant women with COVID. The pregnant women with COVID, they are also subjected to the universal precautions of prevention and control of COVID. They need to also social distance. They need to put on masks. There is nothing that's an exemption. They need to do hand washing. And it is even overemphasized for pregnant women because pregnancy, as these experts will be telling you, is a state, is a physiological state where you have immunosuppression. It's physiologically an immunosuppressing state. Your immunity is not 100%. So you must take extra care. We are trying to tailor this message so that the mother who is not listening, who cannot understand English very well, is able to understand this message. And this has been very critical. We are using the VHTs to make sure they explain all these concepts that sound complicated to our pregnant mothers so that they are able to continue coming for antenatal care. The midwives are trained and they are available. We've not had issues with them. And we need to appreciate them for the work they've done very well. Yes, we've had issues, very serious issues with teenage pregnancies, as our research or literature mentioned, which tend to increase every time we have a lockdown or every time we have a pandemic. I think this is a very serious issue that needs a multi-sectoral approach. I think our Honorable Member of Parliament will also make a mention to this. But most of the teenage pregnancies, as you mentioned, are rotating around the gender-based violence in homes, the breakdown at family level, the lack of close monitoring of these young teenagers, which is very critical for us as healthcare providers or as duty bearers. So we are approaching it from a multi-sectoral dimension. We want to bring Ministry of Gender on board. We are using the community development officers. We are using our community gatekeepers, the religious, the cultural, and the parents to ensure that these issues that are causing the teenage pregnancies, home is no longer safe. Actually, young girls seem to be more safe at school than home, which is a paradox. So we are approaching it by trying to look at all these stakeholders to ensure that we work together and provide guidance on where we can, especially on information on our side on sexuality education and how to prevent teenage pregnancies. And lastly, women being more at risk of contracting COVID-19. This is true. And I think when we are talking to women, it's not a gender issue, but because of their gender roles, naturally, by definition, women are carers. Whether if you're a man and you got COVID, your wife will still care for you. If you're a child, you got COVID, the mama will be next to you. I think it exposes them more. They have a higher exposure risk because of their gender role of being carers. And the women who are out there listening to us, it's very important that they take extra precautions, and they should be the ambassadors of preaching these universal COVID precautions. Now that we have a partial opening up, we should not anticipate another lockdown. We should not think of if we followed everything to the dot. When the healthcare system is overstretched and overwhelmed, inevitably maternal and newborn death will come in. Our healthcare workers cannot perform to the expectation, and this can greatly affect. I think it's telling me to stop. Thank you so much, and I will join in later. Thank you so much.
Thank you very much, Dr. Richard. As you said, we shall come back to you at the time of questions and answers. Now that we've said that services are open, I'll turn my attention to Dr. Imelda to address us on the question of pregnant mothers and COVID-19. There are these questions that are in the public, and maybe you could like to shed some light on this topic. Are pregnant women at risk of contracting COVID-19? What signs and symptoms could a pregnant or a breastfeeding mother have to suspect COVID-19? What should they do if they have these signs and symptoms? Then lastly, you can address us on the question of, do they stand a high risk of getting complications and maybe because of the severe disease among pregnant women? Over to you, Dr. Emerida Namagembe.
Thank you so much to you and to Aweza for this opportunity. Regarding COVID-19 and the pregnancy, already our commissioner has already informed you that since it's the pregnant woman who gets pregnant, and these are women, and in addition to their gender roles, there's that aspect of getting on board. They remain carers in their homes. They remain doing the other things to ensure that the family survives. And then that biological role of them getting pregnant. True, based on the evidence available and the research which has been done, especially in the world where COVID was first evident, there's evidence that the pregnant woman is at high risk. At first, it was not as obvious, but later on, as data emerged, they noted that the pregnant woman is really at risk. And what we've noted that, pregnancy it offers a number of physiological changes in the body, such that some of the symptoms of COVID-19 apparently tend to be symptoms which a pregnant woman would even get. And at times, this puts them at risk that they end up going late to the hospital. Like a number of pregnant women tend to present with a low-grade fever. And we've noted that fever at times is a common symptom among patients with COVID. And then general weakness. Generally, pregnant women tend to have those episodes of being weak, of experiencing general weakness. And we've noted that even patients with COVID tend to become weak. And therefore, we realize that at times, by the time pregnant women come to the hospital, a number of them tend to present with symptoms already when they are having bad complications, because at one stage they are not sure whether they're dealing with pregnancy-related symptoms or are they dealing with COVID symptoms. But true, the symptoms among pregnant women and the rest of the population may not vary a lot, but at times pregnant women are not sure whether what they are experiencing is because of the pregnancy, because of the physiological changes that occur, or because of the COVID. And thus, issues related to the fever, which may be low grade or very high, they may get a cough, and that cough, usually the cough of COVID, tends to be irritating in nature and also associated with a sore throat. And then the general weakness, the poor appetite. Some people will at times present with a loss of the sense of smell. Some people may not get it. But then usually the major worry is when they tend to get issues of breathlessness. Their breathing tends to get worse, and this one usually happens if there's significant lung damage. But remember, again, a pregnant woman, especially depending on the size of the pregnancy, as the months progress, a number of pregnant women, their breathing may tend to become a bit faster, and thus, when it comes to the COVID-19, and especially so in women who are quite big, what we would describe as obese, or when they have their weights much higher, when they're weighing 80 kilos and above, and again, if they have other complications like diabetes, and again, if they have other complications like asthma, if they have other complications like hypertension, and we know that in pregnancy, there's a condition we call preeclampsia, when women experience a rise in their blood pressures because of a number of physiological changes that do take place. And thus, we tend to see that even pregnant women who have suffered COVID, a number of them have also suffered that complication we call preeclampsia, which at times can even progress, and they develop convulsions, and they behave as if they've ever had epilepsy. But just that because of the various physiological changes which do take place, we find that pregnant women are prone to even severe forms of disease. Like what my colleague has already said, depending on the nature of the severity of the disease, if they have mild symptoms, of course, whichever kind of symptoms, when they suspect, we encourage that it's better they have a high index of suspicion so that they can go to the hospital for checkup early than remaining home. Because what we've noted, those who have gone to the hospital in the early stages and they are evaluated properly and initiated on appropriate treatment and given appropriate advice, the outcomes tend to be much better compared to those who go in when the symptoms are already so bad. So we encourage a high index of suspicion when you have a fever, when you have a cough, when you've developed general weakness, or any other related complications. It's better you go to a health facility for a checkup. Luckily enough, they've tried to expand the testing services at the moment, and then later on, you are evaluated, you are examined, and started on appropriate treatment, or even referred to the next level of care. Otherwise, at the moment, although we'll talk about it later on, as we continue to emphasize that prevention is better than cure. The SOPs which have been put in place, the preventive measures of encouraging to put on a mask, ensuring that you try to avoid crowded environments, and ensuring that you try to, the fact that women are generally carers, they tend to be so much in environments when there is a loss of a close one or when there's any other event, they tend to be at the forefront. We encourage that it's better, especially when one is pregnant, to avoid those kind of environments because they are more at risk of getting severe forms of disease. And now that the vaccines are available, because there will be, my colleagues later on will come to that, they'll be saying that what do we do in order to prevent these issues related to severe forms of disease? Or they elaborate further that even now the pregnant women are encouraged to take the vaccine if it's available. So, based on that, I think I've touched on the issues of who is at risk and the kind of symptoms that they do present with and what should they do. We have a high index of suspicion. The best is that go for a checkup so that you are evaluated properly and then you are advised on what to do. Thank you.
Thank you very much. We shall get back to you in case there are some questions that come on the same topic that you've addressed to us. I'll go to you, Dr. Lawrence Kazibwe. Address us on the topic of COVID-19 and mother-to-child transmission. There are these questions that can COVID-19 pass from the mother to the unborn and the newborn baby? Then there's this question of breastfeeding. If I'm breastfeeding and I'm positive, how do I protect my baby from contracting COVID-19? Then the question of which Dr. Emerida has touched on, can pregnant women and breastfeeding mothers receive a COVID-19 jab? And does in any way the COVID jab affect the unborn baby? Over to you, doctor.
Thank you very much, the moderator, and thank you very much, my commissioner and the Twaweza group that have given us this platform to explain to the community and the members of the public about these areas of concern and maternal and child health. First, as I attempt the questions, one, we know that this disease is quite new. That is novel, probably chimeric, and zoonotic, as they've been describing it. And this is hardly 2 years since staying with this disease. So the data on transmission from the mother who is infected to the baby, the data is quite limited. But in literature searches that I have so far consulted in China, in Russia, in the USA, and the UK, this is limited data. In some of the papers, they're looking at, say, 20, 30 mothers enrolled. In some papers, they're describing less than 500 mothers who are positive, trying to see what will happen to their unborn babies. And in most of these, they are describing that it's less than 10% of vertical transmission. That is the infection or the virus passing from the mother to the baby. So in some of the papers, it's as high as 8%, but in most of the other several papers, it's less than even 1%. So with that, we still preach that if all is possible to our pregnant women, they should continue as a practice the SOPs, properly put on fitting masks to ensure that all the air that should get into our airways should be properly filtered of these viruses, and the material should be right. The second bit is what about those that are born after delivery? What would happen to the unborn child? Oh, sorry, I forgot to mention something about the Ugandan setting. Yes, we have conducted deliveries in our country, and that is Entebbe mainly, Mbarara, and then Mulago Specialized Women and Neonatal Hospital. You may ask me, as a disclaimer, me who works in Kawempe, with such huge numbers, what have I been doing? I'll begin by saying that we're guided by the Ministry of Health that having such a crowded place is that we should be vigilant and carry out screening of the clients reporting to us. And then once we find clients with the COVID positive, in the earlier times, would send you to designated treatment centers for further evaluation. But with time, as the guidelines rolled out, we are guided that there are those that may not be too sick to require being moved to the COVID treatment centers. So pregnant women who had especially oxygen saturations above 94, 95%, would enroll them on home-based care. Whereas, and that's what we're still doing up to now. Those that are sick, that the oxygen levels, blood oxygen levels are less than 90%, those we need to redirect them to the COVID treatment center, that's in mainly New Mulago, and then enroll them into 5A, that's where we've been caring for them. Those that we have conducted deliveries on over the probably last 10 months, we have had, if we delivered 10 babies, we found that a majority of these were negative, especially 2 babies, apart from 2 babies who tested positive in the first 24 hours of their deliveries. And we're using the polymerase chain reaction test, which confirmed that they were positive. So we're also still looking at the data to see whether there's a potential of vertical transmission. Amongst these babies, again, especially at Women's Hospital, a baby was born negative, and then probably after 72 hours, again on testing, we found that the baby had turned positive. That was quite unfortunate, and it means that we're not probably, however much as we explained, that the mother and the caregivers and us, the health workers, should put in place precautions to ensure that the baby stays safe through the social distancing, that we shouldn't have so many attendants coming in. We should at all times wash our hands properly with soap and water, plus also alcohol-based sanitizers. We should also go ahead and ensure that the mother, as she breastfed her baby, that should properly put on a fitting mask. And this is what we've been telling all these people that have delivered in Preparium, to try and ensure that we do what? We prevent or break the transmission cycle or getting the baby infected. So that was quite unfortunate. But we still encourage and preach to all those that are in the health system, and it is passed on to even the lower health facilities, even the home-based care, that once they get signs that require them to get into health facilities, like delivering under-skilled birth attendants, should have begun by those that are coming for neonatal care contact visits, to really practice these SOPs and ensure that we deliver a safe newborn, we deliver this newborn safely. So if we practiced all these bits, the SOPs as guided by Ministry of Health and WHO, we probably would have less chances of transmitting the virus to the baby, because once it gets into the world, it's now the usual transmission processes that carry the virus to the baby. Hardly have we seen documented evidence that it crosses via the milk as the baby breastfeeds. The role of the we understand the pathogenesis, that this virus actually causes severe forms of diseases, and worse off with our population, let alone those that are having other coexisting comorbidities, HIV, diabetics, and hypertension over years, and sickle cell and all that. So the other bit is quite lethal or fatal, that once it gets you, it's likely to really cause either mortality or morbidity, and we have been witnessing this in our treatment center in Mulago National Hospital, that we have lost some mothers, like the commissioner told us as we began. So the mainstay is probably for now, as everybody is preaching, that there is great benefit of use of the vaccines in the pregnant women. Now there is a bit of small caution on the first trimester, where we know from the science that the vaccines have with them small particulates that are just to trigger the immune system, but we are not very sure what they can do with the first trimester, where we expect most of the different parts of the body and organs forming. So if we are to select on women, the general message you put out there for us who are in these low-income countries, we have these huge populations, we are so much at a community level. You understand that family members are not less than 5 in a given homestead. So we would encourage that all of us almost get to have our mothers vaccinated to receive its protective effect. But in other places where you have probably low transmission rates, they are probably still at level, wave 1, 2, they're able to do contact tracing and all that. There is precaution that first trimester may be left out, and then probably vaccination continues with the second, or starts with the second and third trimester, to try and receive these benefits of the vaccines that are on the market currently. Like I will also preach to all like what other colleagues have said, previous speakers, that the message that we should put across up there to the communities is that one, we encourage that the pregnant women do not expose themselves. So stay away from super spreader events, the burials, weddings, any community gathering that would increase the chances of picking these viruses. Two, try to ensure that we also discourage when you have siblings, these little toddlers running around all the villages, try to do proper parenting. I'm glad other ministries are coming on board to see how to engage these siblings or toddlers in the home to stop picking probably this virus, or probably chances of picking viruses from the communities. And then 3 is to practice the safe SOPs that have been put forward, especially the masking up, proper masking up, not just masks that are just covering probably part of the nose and probably the mouth, and you think that we are doing great in terms of preventing this. I thank you very much for listening.
Thank you very much, Doctor. We shall get back to you on the same topic in case there are questions and they require answers and clarification. I'll go to Dr. Dale. Now, a baby has been safely delivered and is okay. Address us on the topic of COVID and address us on the topic of COVID-19. address us on the topic of COVID-19 and babies. Does COVID-19 affect babies? How do we know that our babies have been affected, and what signs do they present if they have COVID-19? How do I seek immediate care in case I suspect my baby to be having corona or COVID-19? And how do we protect them as parents and as mothers? Over to you, Doctor.
Thank you, moderator, and I'd like to thank Twaweza for inviting us together with the Ministry of Health. The important aspects that we need to know about COVID-19 compared to the normal population. So it puts them immediately at risk of all forms of infections. So most importantly is if that baby is born to a mother who is COVID-19 positive, the first important things are to initiate the barrier protection. And it has been clearly highlighted that we need to ensure that the mother wears a mask. That's the first thing. 2, hand washing. Every time the mother will be engaging the child for breastfeeding, we'll have to ensure that the mother is able to hand wash. And would like to emphasize hand washing because there are other methods in protecting the skin, like sanitizing. But remember, there's a big cost associated with asking mothers to have sanitizers with them. But if they are to use the sanitizers, you have to ensure that the percentage is slightly lower. We tend to use 80% generally, but for a newborn, you would like to use a 60% sanitizer. And this requires now the government of Uganda through the Ministry of Health to avail these additional percentages. And that's why I would like to emphasize the importance of hand washing. Yes, this baby can get COVID if exposed. Dr. Kasibwe has mentioned that several studies have looked at the risk of passing on the COVID infection from mother to child. And it's also important to note that some of these studies have very small numbers. And by small numbers, it means you cannot really say or confirm scientifically that it may occur. One of the most recent studies that looked specifically at the liquids or the fluids that are passed on during the birth have shown less than 5% transmission. Even looking at the breast milk, because remember, when a child is born, we ask the mother to initiate breastfeeding within the first hour. So they have looked at the milk substances and seen that still the percentage might be there, but it's really, really low. And these milk substances, they looked at the DNA of the COVID virus to see if it was able to be passed on, and the percentages were less than 5. So that's the first thing. Secondly, what are the signs? Babies will not give you so many signs. One key thing that you should remember is that they may be irritable. The babies will cry, the babies may have fevers, the babies may have fast breathing, and those are the signs that we look at in a newborn. As the baby grows older, there are some other things that you'll be able to look at. The running nose or flu-like illnesses may be present, but it's important for us to note that. In terms of care, what can you do? First, if a child has any signs or symptoms, you have to confirm a diagnosis. And by diagnosis, it means you have to take off a sample from that baby to confirm if COVID is present. This is done as early as when the baby is born, or even 24 hours or 48 hours after birth. And if the child is positive, they need to seek care. Most times the babies are symptomatic, and we tend to test based on the severity of the mother's illness. And that is where we would look at the care for the child. Another important thing we should emphasize is where does the mother take the child? If the child is born in a hospital and the mother is there, they are fortunate enough to have care within the hospital. If they're not in a hospital and they're at home, then we normally recommend the nearest health facility, at least a health center 3 and above. And depending on the severity of this child's COVID illness, they may have to be referred to other centers. But we also have the challenge of movement. how will they move from one center to another? So these are some of the challenges that we do experience when it comes to managing newborns and children who have COVID. Thank you very much.
Thank you very much, Doctor, for giving us an insight on how to protect our babies from COVID-19. I'll come to you, Dr. Olive, on the issue of antenatal care during COVID-19 pandemic. How and why is it important to attend antenatal care? And how often should mothers go for antenatal care? And what are the dangers if at all they miss? Because you realize we've been having lockdown, challenges with movement. Someone might say, I might not go for antenatal care. After all, I have no means. What are the dangers in case someone misses? And maybe you can also give us an insight on what are the current leading causes of maternal deaths and how do we prevent them at a community level. Over to you, Doctor.
It is important, therefore, to make sure that once a person has missed 1 month, 2 months, and she's a woman in reproductive age, she should assume herself pregnant and therefore should present herself to a health worker for understanding whether she is pregnant. And those first 3 months, we can say maybe up to 4 months, is what my colleague called the first trimester, when so many things are happening to both the mother and the baby, and we need to understand as health workers who you are, how are we starting you off, what is your general physiology, anatomy, and what are those factors operating in you which we need to monitor, including the baby, what is happening in the baby. And therefore, it is going to be very critical for you to present in the first months so that we can pick important diseases which you may have. Some of us, and many of us, could be starting off with the diseases like hypertension, diabetes, sickle cell, low hemoglobin levels, that is low amounts of blood. You could be starting off with HIV, you could be starting off with hepatitis, you could be starting off TB, name it. You could be starting off with several things which are going to affect the newborn or the fetus which is growing in you, and which are also going to affect the normal way in which a pregnancy is moving. And we need to see and to understand this early. As skilled health workers, people who have been trained to do obstetrics and midwifery, so that we can support the total experience you have to go through pregnancy and advise you on how you're going to be delivered safely, so that you come out with a safe, you yourself healthy, and the mother and the baby also healthy. We are inviting mothers, and the Ministry of Health guidelines are saying, we've increased the number of contacts we want you to make with the health system. We want you to make sure that in the first month, you are seeing the health worker at least once. At least come once and we start off the baseline. Who are you? And how is your baby? It could be having abnormalities as well, and we need to do interventions. And as you move into the second part of the pregnancy, the second trimester, 4 to 7 months, you need to avail yourself at least twice. We are not asking for too many times. So that again, we see the physiological changes as they are taking place, the diseases as they are moving, and we also give you some health-related education, information. We give you anti-malarials, because you know malaria is also endemic in our country, and we need to, and it's a serious condition in pregnancy, and for it, it also causes serious complications. And we need to give you nets to avoid the mosquitoes coming to you. We need to give you medicines to prevent it from growing in your body and affecting the baby. We need to make sure you don't have syphilis. If you have, we treat it. If you have HIV, we manage it. So we need to manage you quite early so that we avoid the adverse problems. We need to detect some abnormalities. Like sometimes that part which is called the placenta, the one which feeds the baby and on which the baby hangs as it is growing, the afterbirth as it is called in some language, we need to know where it is placed. Because if it is also placed wrongly, it may predispose you to certain complications of pregnancy. And we need to detect this early and manage you according to what you are. So we are just asking for you to come 2 times so that a person who's well-trained, a person who can plan with you according to what you are, where are you going to deliver? How are you going to move to that health facility? What resources do you need? How will you get there? When do you need to get there? With what do you need to be there with? In order to experience, a good experience of pregnancy and have a safe delivery. If you don't avail yourself to the health facilities, with or without COVID, a pregnant woman must come to be monitored on how she is moving. Because I've told you, even what starts off appearing normal, without even the complications, without any diseases, can within a day change. A pregnant woman who is healthy in the morning may be completely different in the evening. So you need to come according to the schedules which have been given by the Minister of Health. In the last part of the trimester, there is evidence, there is scientific evidence which shows that you need to come more times than you've been coming when the pregnancy was still small. Because this is when we see that most of the diseases that affect the outcome of that pregnancy begin to appear, begin to express themselves obviously, and they can easily be picked. So we are asking you to come 5 times. Every month, make an interface with the health facility so that they can check what amount of blood you have. Are you ready for the delivery? Because with delivery, you lose blood. And if you don't have enough, the health workers need to intervene. Have you got an infection anywhere? We need to treat that early so that you don't go to delivery with that infection. We need to understand whether you have any other problem which we need to monitor as you continue to progress with the pregnancy. So several investigations will be done. Information will be given to you according to what they detect. And they will be asking you to come with your spouse, your husband, your relative who is asking, looking after you, so that you are able to plan together. And you need to experience the environment of the health facility. You become used to it, you become friendly, you start the communication journey with the health workers who will be looking after you. And you ask the necessary questions. We are saying that this intervention must be done in a health facility which is equipped with the skilled people, midwives and doctors, who can do something about a problem if they detect it. So 8 times, we have moved away from 4. And I've said in the first trimester, you come once. In the second trimester, up to 7 months, you come twice. In the last 4 months, we want to see you 5 times. And that is the importance of making sure that we correct whatever is going wrong, and we detect what we can and treat it in time. We are calling on men, the husbands, the spouses of these women, to make sure that they are always around when they are required to come. Because they need to participate in the care of the mother from the pregnancy itself, the delivery, and after the delivery. This is good for the mental health, for the physiology, for the progress of pregnancy, and the progress of delivery for the mother. If we do proper antenatal care, we are likely to detect problems which may become complications and actually cause us the death of the mothers and the deaths of the newborns. And that brings me to the second question which was asked. Or, before even we move to there are some danger signs which you need to look for as a pregnant mother, and even your spouse, your husband, your mother who is looking after you if you're pregnant. If a pregnant woman ever tells you that I have a headache, I'm not seeing very well, you need to take this very seriously. A headache which does not go away, which doesn't easily respond to simple medication like Panadol, always signifies that you may have the high blood pressure, the Preeclampsia, Eclampsia syndrome, which our colleagues were talking about. It's a special raised high blood pressure in a pregnant woman, and it has very few signs, but it usually has that headache. So a woman with a headache, a pregnant woman with a headache, must expose herself to a health worker so that we know why are you having this headache. Is it an innocent headache, or actually you're running into a raised high blood pressure? If you have a high fever from any, cause as a pregnant woman, you must report yourself to the health facility, because it also results into various complications to the mother, and first maybe to the fetus which is inside. It is the one which feels that very high fever first. And you may get an abortion easily. You may get a miscarriage. You may get a premature delivery. That fetus may get out because the temperature is so high if you don't come early for us to treat you. If you get a rather severe abdominal pain, which you have not been having, and you notice it's not regressing, it's intensifying, you must expose yourself to the health facility. You must come and check. You must come and report that abdominal pain. It may signify an abnormal event happening inside yourself, either inside the uterus itself and where the placenta and the baby are. It may even be related to the structures that are related to the uterus. So you need to come, depending on the pregnancy level, how big is it? There could be various things as to why you're having abdominal pain. If you're having pains here and there which you don't understand, there are infections which could give you this pain, and you need to report them early because they translate into infections in the unborn baby, into infections in you, which need to be detected early. The other possible danger sign you may obviously see, but which is not very specific for hypertension, is that excessive swelling everywhere, including the face. Because many pregnant women will have swelling in the lower legs. But when you start swelling everywhere, even including the face, it may be signifying, again, high blood pressure. And you need to really check. And now you are having added symptoms because of the added diseases. Those coughs, difficulty in breathing, you need to report. These are becoming now obvious danger signs because of the added diseases. And any person detecting, if these women are telling you such things, you need to come early. If you are feeling weakish, it may tell us that you don't have enough blood and you need to go to the health facility Because again, a woman who has anemia, as we call it in our language, is a danger if she goes into delivery without adequate blood. Let me move to why women therefore die. If we are unable to detect these problems early and do something about them, why do they eventually die as a result of pregnancy-related causes? We are now going into that difficult subject of high maternal deaths, high perinatal deaths. The Commissioner has told you we are getting increased numbers of stillbirths, but also the women who are dying still remain. They could be reducing slightly, but the previous data which we had in Uganda did tell us that almost about 16 women die every day in Uganda because of pregnancy-related causes. And they die directly because they have developed complications of hypertension, complications of bleeding. Bleeding after childbirth is certainly the highest cause in Uganda and in many countries in Africa. Many women bleed to death after they've pushed out the baby, even normally. There are conditions which even lead to increased chances of why you may bleed after delivery. Women who have delivered very many children, high para, 6, 7, 8, 9, the uterus is getting weak, it's not contracting very well, it has chances of relaxing, contracting, and therefore not able to control the amount of bleeding. So we are asking women and their spouses, their husbands, to really consider having reasonable numbers, at least 5, in terms of pregnancies. Because the higher the parity, you are increasing your chances of bleeding after childbirth. And this is the commonest. But remember also when you've had a cesarean section, an operation which is done when you cannot deliver through the usual birth canal, it also has some increased chances of you bleeding more than if you had a vaginal birth. So women who have had operations, operational deliveries, also may have a higher chance of bleeding after childbirth. But I also informed you that there are conditions of bleeding even before childbirth, when the placenta is placed in the wrong way, when the placenta also bleeds when it is still inside. And when you deliver, when you have had these conditions, your chances of even bleeding more after delivery are much higher. Women develop infections, sepsis, especially women in our rural areas. The environments within which they are exposed just around childbirth are not so clean. Women are touched by so many people in the villages, sometimes even before they come to the health facility. The things we use, we as women, during childbirth must be completely clean. And if you are exposing that mother within an environment which is not so sanitary, which is not so clean, as it may happen in villages, people trying to help you to deliver, infection is likely to start climbing in your canal, and you can actually die post-delivery. But I want also to say that next to these two conditions, that is very bad bleeding, PPH, and hypertension, we get this infection, which is number 3 on the cause of death. Infection from the environment, infection from you yourself, you're already having an infection of some sort, you may die. The other causes of death directly related to the pregnancy involve if you've had other conditions As I said earlier, you may be having very little blood and you're delivering and bleeding more. You may have severe malaria, which is not treated in time. It can cause death in pregnant women because they are already immune compromised. You can die of complications of HIV as a disease. If you are diabetic and you're putting on a pregnancy, the complications of diabetes could be also worsened during pregnancy, and you may die of those other morbidities complicating the pregnancy you have. So it is important to always check who am I and how am I beginning the pregnancy and how can the health workers support me to go through the process which I already have. COVID is added on now as a condition which is also worsened in pregnancy. So how do we avoid all this? Now we know that actually women can die. And here in the central region, we know that every pregnant woman at least has a foot inside the grave, one, and one outside the what? The grave. And that's why we say, welcome back from the war. Because it's a what? A war. A pregnancy, you have been taken into a war zone. And you need artillery, you need arms to help you do what? Survive. And that's why we need everybody, including yourself, around yourself, to begin to protect, prevent, and expose yourself to a health system which can help you. So by prevention, we start with you as an individual to take on the correct choices. You and your husband, because I think the pregnancy belongs to both. Are we making the right choice to go to number 6, number 7, number 8? Okay, if we've decided like so, are we making sure we are attending antenatal? Are we sure we are preparing to deliver in a health facility? Are we sure we are not planning an early pregnancy? You have heard that very many children, I call them children, 12 to 18 are pregnant. That child should not be pregnant because pregnancy, that child inside you acts like a parasite. So how can a child have another child because itself is growing and you are saying it is also growing another child, which also has its own needs? We have some evidence to show that adolescents who are pregnant also do not perform very well because of the socio-economic environment within which they find themselves. But there are also conditions of pregnancy which seem to appear a lot in adolescents who are pregnant. High blood pressure, bleeding after birth. Malaria also becomes very high. Sometimes they start off with a low HB because they've been bleeding a lot. So a child should never be pregnant. So you as an individual pregnant, an adolescent, should try and say, how do I not become pregnant if I'm sexually active? I should not be pregnant until age 20 and above. With my spouse, we need to take that decision. So that if I'm pregnant, I must go to the health facility. Those are at individual level. I must prepare for some costs if I'm pregnant. That is poverty now and resources for caring. So we must have a plan to take us through a normal pregnancy, but also prepare for an emergency. Because I said every pregnancy carries a risk. You may be the one who goes through normally, but you may experience an emergency that requires more money than you thought it would. Even moving you from the home needs money. So at the community level, at the family level, we must prepare whenever we have a pregnant woman that we need to transport her. When she says, hey, I have pain, we must be prepared as a community to move her. But how are our community systems to move anybody who is in need, especially transport costs? How are we prepared as a family with a pregnant woman? How are we prepared as a community, as a village? And so we need village systems How are we prepared as men, as husbands of these men, to look as husbands of these women? They are not husbands of men in Uganda yet, but they are husbands of women. How are we prepared to move them? So male involvement, community involvement in ensuring that all pregnant women who are there are actually able to access health services. How are we helping each other to sustain a health system which the Commissioner is looking after? How are our parliamentarians, how is everybody advocating and investing in the health system? Because many times when you come to our health facilities, we health workers are still few in number. Because you, on the other side, the community, the population has increased out of proportion with the resources we have. We don't have enough health workers because family planning is not so well practiced in Uganda, and we need to increase the rate at which we are using up contraceptives and planning for a small family. As I end, we need to support each other, to advocate, to have adequate medicines in the health facilities, to have facilities near our homes functioning very well at level 3, level 4. We need to have more financing in the health system to be able to run, because sometimes you come and we don't have enough of what we need to use. So the health system must be given a bigger push, given the numbers of women who are now delivering or pregnant. So we have interventions at individual, at family community, engaging men, and we at the health facility, at the health systems level, making sure that the interventions that need to be put in place are actually put in place. So it's a multi-sectoral response. Is there transport? Are women able to move? Is there a broken bridge? We cannot do it from only a health sector perspective. We need to engage the highest level of governance and leadership and engage all the other sectors. Educate women, move them out of poverty, educate the girl child, feed it from infancy so that it grows a body which can allow the baby to pass through. There are so many players in preventing maternal deaths. So many sectors which must come together. We have our role as the health sector, but we need to be complemented. Thank you very much for giving us this opportunity to talk about a very important subject. Thank you.
Thank you. Thank you. Thank you very much, Dr. Olive Sentuomwe. She's the Family Planning and Population Officer at World Health Organization. Thank you very much. Now I'll turn to Honorable Sylvia Tumwekwase. She's the Member of Parliament, Kamwenje District. She has been in this sector. She knows what the sector goes through, and especially about maternal child health. You've listened to all the discussions, and that's why I decided that you come at this point. Want you to give us an insight on the role of Parliament and reproductive, maternal, newborn, child, and adolescent health. And maybe address us on some aspects. Recently, we saw a task force from Parliament moving over the country. We want to know, was maternal health part of the area of interest, and what were the findings? And also may give us an insight on what Parliament can do on the issue of teenage pregnancy. As Dr. Olive kept alluding to it, she said it is a multi-sector approach to address most of these issues. So how can Parliament help us to have, also as maternal health, also have the parliamentary caucus, like the malaria team has? So over to you, Honorable.
Thank you very much, Moderator, the Commissioner, Maternal, Newborn and Child Health Programs of the Ministry of Health of Uganda, plus my fellow panelists, vacuum participants and media present. My name is Sylvia Vahireira Tumwekwase, the woman member of parliament for Kamwenge district. And I must say I'm very happy to be part of this meeting, this discussion of a very important subject to our health, to our people, to our country. First of all, I should say that the team that has been moving around the country, the health team that has been moving around in the past recent days, has been with different objectives. The core objectives was on COVID-19. COVID-19, that is about contact tracing. If issues of contact tracing were well addressed at all levels, then diagnosis and also treatment. But also, the team was looking at has the health system or health workers zeroed all their energy on COVID and have neglected all the other services, which also included maternal, newborn, and child health services. So we were also looking at that because much as we are hit by COVID, other conditions have not gone away. People are still getting infected with malaria and dying. People are still getting maternal challenges and dying, neonatal challenges. So we were also looking at that to see that we should not, the health system should not zero all the energy on COVID and then we leave the other conditions to disturb the public. We are also looking at issues of human resources for health, logistics, like medicines. So some of the findings were that our system, I must thank the health system, the Ministry of Health, so much in that it is all-round system. Much as we are in a panic mode, like one of my colleagues has just mentioned, that this outbreak is hardly 2 years, our health workers have still kept attention on other conditions as well. They are paying attention to COVID, also paying attention to other conditions. So we are also looking into this, and there are no significant gaps, except we found some gaps on human resources for health, where we found that health workers are working under some increased workload pressure compared to the previous days when we did not have the pandemic. Why? Because some have contracted the infection, and unfortunately, some have even died. So when a health worker contracts COVID-19, the average time he or she can spend away from duty is, say, 3 weeks. So you can imagine a health worker being away for 3 weeks, which was not planned for, which was not on schedule. It creates a lot of gap. And that brings a lot of workload pressure to the other colleagues who will have remained at work. So we found that as a challenge, and it is in our report, and as parliamentarians, we are committed to working with the Ministry of Health and working with other line ministries to see that in this pandemic era, the Ministry of Health can plan on the issues of generally revising the staffing norms, because we have to prepare for the worst. We don't know when the pandemic is to go away. And as you know that our nurse-patient ratio in Uganda here is still miserable. The doctor-patient ratio, I think the nurse-patient ratio is 1 nurse to 10,000 patients. Yeah, that is miserable. Then, sorry, 1 nurse to 25,000 patients, 25. That is nurse-patient ratio. Then the doctor-patient ratio is at 1 to 10,000. You can imagine one doctor being responsible for 10,000 citizens of Uganda. Well, people do not get sick at the same time, but still, it puts that doctor, that nurse, at a very high risk of working under great pressure, especially now that we are hit by this pandemic of COVID. So, generally, the details of maternal, neonatal, and child health were not looked into. The team was basically looking in detail issues of COVID. And this brings a responsible question or a responsibility to us all, like Dr. Sentumbe said, issues of maternal, neonatal, and child health should be a collective effort. Indeed, it should be. Everyone should play their role. From family level, from family level to community, to health systems, and so on. So, this calls for us also as parliamentarians that we have a great role to play, especially the advocacy role. We have a great role to play. We cannot wait to sit down and leave the core responsibility to the Ministry of Health. Advocacy role for budget consideration, sensitization and mobilization, and so on and so forth. The good thing I have to mention that we have a fully fledged committee of health at Parliament, and majority of them are professionals. I did not tell you that before I joined Parliament, I had worked in the health system of Uganda for the last 20 years at all levels. I have attended to mothers deliver in the labor ward. I have managed a district health system as a district health officer. I have also managed a district health system as an assistant district health officer, particularly in charge of maternal child health services. So, the Committee of Health in Parliament will really be there for all that it requires to see that the government puts attention to these services, because we have been in it, we know the gaps, and we know really why we have to advocate for our people, for our Ugandans. So, if I can go to the question of teenage pregnancies, I have to say that teenage pregnancies in this COVID era is a challenge, and teenage pregnancies is a sign that there has been areas that have not been addressed in different points of service delivery. Some of these areas unaddressed that I'm talking about is issues to do with sensitization, mobilization, also availing family planning commodities at different levels of care so that they are easily accessed. So, when COVID had just started, I remember most parents could even go on television and other media platforms saying that the government should help us, government etuyambe, and you would find people on streets and in communities making fun. And now, what do these parents want the government to help them on? You know, but these parents were right. Teenage pregnancy is somehow a sign that there is gap at some care points. So we need to increase sensitization to these teenagers, especially on telling them to avoid involvement in risky behaviors. Also, availing family planning commodities everywhere, like I had said. It is very evident, we have proved it beyond doubt during this pandemic, that boarding schools have been doing a very significant job in keeping the teenagers safe. For all this time, we have been in lockdowns, on-off lockdowns, and schools have been also equally affected. Teenage pregnancies have somehow increased, and parents have found a challenge with their children at home. So we must greatly appreciate that schools have been helping parents so much in keeping these children safe. But also, parents should try their level best to avail enough time to their children, because once there is lockdown, there is no shortcut. Parents have to avail some time to their children so that these catastrophes do not occur as we wait for what will happen next. What I have to pledge as a member of parliament and also a health worker who has been in the health system of Uganda for the last 20 years. By the way, I also managed a project which was a result-based financing project, and we were basically funding maternal, neonatal, and child health indicators in the whole of Resort region. I was managing a project of result-based financing funded by the Belgian Development Agency, Enabel. So I understand really what it requires for us as a country to have these services to the dot. So I pledge my commitment and the commitment of my fellow parliamentarians, because I sit on the health committee. I'm a member of the health committee at Parliament, to work with the Ministry of Health and all other partners that are in this area to see that really we increase and intensify the sensitization. Also, advocate for the increase of budget for these services so that there is no any gap that is left unbridged. I want to thank you very much once again, Commissioner, for inviting me to this very important meeting, and my fellow panelists plus the listeners. We shall do our best as parliamentarians to work with you. I thank you very much.
Thank you. Thank you very much, Honorable, and thank you for the commitments. We look forward to working further with you on addressing issues of maternal and child health in Uganda. It's our Uganda. We have to work together to address most of the issues. Ladies and gentlemen, we are now going to the session of questions and answers. We only have 15 minutes to end our discussion for today. I want to appreciate a team from the ministry and doctors who are appearing online and are responding to questions that come via Zoom. Thank you very much. You're easing most of the work we would have done here. So I'm going to allow questions from the media and journalists who are inside here. You'll have to, can I see, yeah, Vincent? You kindly direct a question to someone.
Thank you so much. My name is Vincent Siriko. I'm a journalist from Radio 1, Dakavos. Maybe one thing you forgot as a panelist or the moderator was to congratulate His Majesty upon his 28th coronation, because he's a key stakeholder in this kind of strides, being a goodwill ambassador of the United Nations in this kind of efforts. So it was key that as a Muganda, I remind you. The other is about the statistics. Before I go to the report, Doctor, you presented your report. Sorry, if I go to the report that was presented, it cited home-based care maybe as an alternative to safe care for mothers, expectant mothers, because it's when you acknowledge maybe the mother is at risk or not. But then, safe and home-based care services are not regulated, if I may use that word. We have no protocol, as we, the vulnerable, the people, the wananchi, on how best we should ensure it's successful. Now, this goes to the commissioner, Mr. Mugahi. How is the ministry planning to see that home-based care as an alternative to flagging or to flopping the health facilities is actualized? What's government's plan in the ministry's perspective? That's what I want to know. The other is on the statistics. The doctor here from Parliament presented the statistics, maybe he just altered one. Uganda's, if you compare Uganda's doctor to patient ratio, we are doing bad in the region. You said 10, no, it's 25. It's the other way around, nurses to doctor ratio. Population to nurse ratio versus population to doctor ratio. It's 1 to 25 for doctors. And in Kenya, it's 16,000. Tanzania is 20,000, and Rwanda 12. Now, I come in here to ask also Dr. again. During the results assessment report, which it was released the other year before COVID, we are credited for having good policy proposals, which most of these countries are basing on to implement their health response programs. Where are we failing as a country to see that we take lead? Because in the region, we are doing bad. If we have only a doctor per 25,000 people who need help, and we are lagging. The next is Tanzania. So I just want you, why are we lagging as a country to implement these good policies that we are talking about in reproductive health, HIV, name them. But now that we are in reproductive health, attributed to this particular one. Doctor from Kawempe, we recently saw an ugly scenario where a patient fell off from the window of the hospital, and police spoke out. The hospital was not clear on this. Maybe now that we have you here. They talked of care at the facility and so many other issues. If you could clearly bring out this issue today and tell us what caused this incident, now that we have you, sir, here before us. Finally, the youth and the adolescents. Campaigns have been carried out by the ministry intensively. We see adverts and things of the kind. But still, we are not scoring as high as we would like as a country. Given the prevalence of high teenage pregnancies, if you go to the outskirts of the city and the villages there, it's very bad. Apart from the campaigns and the rhetoric talk, what is that thing that we need to do meaningfully to see real results?
Next.
Thank you. My name is Jingo Francis. I work with NTV. Mine is just simple. I just only need statistics from the commissioner. In his remarks, he said that there's no doubt that we have lost women, we have lost newborn babies in this period of COVID. And you have been monitoring and you have statistics. We just want to know, for instance, within this period, since we had, within how many women have died in this country as a result of COVID-related death of women in this country, and how many newborn babies have died, COVID-related. And probably not only looking at those who have died. You said that you received women, pregnant women, you have cared for, and some of them come to the hospital when they have COVID. How many lives have you saved? Babies and women within this period of time. Thank you.
Thank you, Jingo. Yep.
Yes. My name is Flavia Nasaka. I work with Uganda Radio Network. I have questions to both the Commissioner and the Deputy Director, Kawempe. One of the issues that come out of the report is psychiatric breakdown by mothers, by pregnant women. I would like to know how you're incorporating mental health care into antenatal and other programs directed towards pregnant women. I would also want to know what was happening at Kawempe in the second wave. We know in the first wave that they had made some changes, but the numbers weren't as big and they were forwarding them to the treatment centers, as the doctor said. What changes happened? You could paint for us a picture of a hospital like that is always crowded normally. What new things did you do in the second wave? Yes, and again, on the figures, we would like to know the differences between the first wave and the second wave, since they are weekly updates of these figures.
Thank you very much. Any other question? Yes, there is this gentleman.
Yes, I greet you all. My name is Dennis Chove once again. I report for Bukedea TV. Yes, Mr. Commissioner, I think we need to discuss some interventions to reduce the cost of health. For this particular matter, we are talking about maternal health. You're going to realize that many things have actually worsened when you look at the cost of affording such services. These days, we see some people, it costs some people so much money when you look right from the stage of conceiving. Some people are actually spending so much money, you conceive throughout the whole process. And at some point, we get to think that this could also be a point that at least that is pushing some people away from coming for medication. Yes. So, are there any interventions as government you're putting in place to make sure at least the costs don't burst? Thank you very much.
Thank you. Any other question?
Thank you. My name is Solomon Dwambla from Power FM. Considering the disruptions in the sector, where does this put the country in regards to attaining SDG 3 targets, especially reduction of maternal health, maternal mortality, and infant mortality?
Thank you. Is the question clear? Dr. Richard. Okay. Any other question? If there is no other question from the people here, let me take these 3 questions that have come online. One is, post-COVID pandemic, what can we do to get back the teen mothers on track? Question 2, could we as a country be knowing that there could be a general community perception of healthcare center under COVID-19 response as being exclusively for COVID management and highly transmissible. I think this question is talking about a general perception of mothers thinking that all centers are responding to COVID, and they have fear of accessing services in facilities for fear of contracting the disease from there. 3, hasn't the COVID-19 response got an association with mothers delaying to decide, seek, and get care? Question 4, hasn't COVID-19 response had an effect on provider competence for maternal child healthy services under the pandemic? Other questions coming on from online. This is not a bit clear. Are we aware of the key interventions needed to address these challenges? Second, last, can we have adequate PPEs for our midwives? We are having many of them turning positive. Lastly, the recent release for COVID emergency fund put the recent release for COVID-19 emergency fund, but nothing was guided to the maternal child health services. Why? Those are the questions from online, and I think we can start responding. I think it will move. I think most questions were for Dr. Richard and Dr. Lawrence. Let me start with Dr. Lawrence.
Thank you very much, moderator, and thank you very much for those that were listening to us attentively, and you, the journalists, for this feedback and seeking for clarity. I'll begin with that unfortunate incident that happened at Kawempe National Referral Hospital, where we had a mother who had just delivered through assisted delivery through cesarean section. That was quite unfortunate, but we internally looked at what transpired, especially in trying to how did the clinicians handle this client prior to surgery. They were mainly driven by how she presented, that she urgently needed the intervention of surgery and forgot about the mental status, the mental state exam, that this mother had much more clues that she had a challenge mentally or depressed due to lack of support with the partner and the entire family. So we went ahead and had operated on her. And unfortunately, the baby was dead. So with all these piling up into her, and in the early mornings, there are indications that she was starting to have those suicidal tendencies, and they were alerted. So we were preparing to move her. We had given some medicines to try and calm her down. She had on several occasions tried to do what? To try to jump, and staff tried to restrain her. So in the morning, as we were preparing to move her to Butavika National Hospital, unfortunately, as the members had taken her off their eyes, trying to change shifts in the morning, that's how unfortunately she went through the window and probably died, jumped to her death. May her soul rest in eternal peace. So lessons that we pick from this, we have tasked, we passed on the message to all the clinicians that please concentrate on not only what brings this client to the hospital, but also try to really do a thorough mental state exam, try to appreciate surrounding features or issues surrounding this client presenting to the institution. Try to capture this early, and we've been doing so for a while. Remember, you're a national hospital, but with a special status that we are having 2 directorates, mainly pediatrics and obstetrics. In case we need any other services, these are within reachable distances, 15, 25 kilometers away. We can quickly move these clients and then they are seen by these specialists in these facilities. But we have the emergency medicines to quickly start off for these clients. We also make phone calls or even texts or any other forum to try to reach out to these specialists and try to give the quick remedies to these clients before moving them. That is what happened at that particular incident. We tried to talk to the family members, but of course, the police came in full swing to try to establish the facts surrounding what happened. Thank you very much, Mr. Chisembo Vincent. It's a great omission. Let me also take this opportunity to join all the Baganda to congratulate our Kabaka of Uganda upon this anniversary of the 28th year on the throne. So I also prodigiously join all the Baganda to wish our Kabaka well on this day of the celebrations. Yes. Mrs. Nasaka has asked me about our incorporating or being able to incorporate psychiatric services, especially at this time during the pandemic, because the stress is not mainly only for the clients we see, but generally all of us, even the health service providers, we are closely working with the Ministry of Health, and we have already highlighted this concern that we too need some form of either psychiatrist or psychologists coming to us, try to give us sessions and ensure that the mental state or psychiatric evaluations are probably done or incorporated programs to try and address mental health. But that said and done, through our education talks, I wish many of us can probably pass by and see what we are doing. Apart from giving the routine scheduled program talks for a particular contact, we used to call them visits, but now their contacts may be actually physical or even virtual. Someone can raise with a call. But bear in mind the numbers we have, yes, we try to address some of the psychiatric concerns of our clients, but if they are quite beyond our capacity, we have referred these clients to either Chirudo for organic evaluation, but mainly Mulago and Butavika for further management of these cases. So we have counselors, we have psychologists, especially attached to the HIV/AIDS program. For these members that are offering these services, we too always consult them to try and see that once we identify these clients, we quickly refer them for appropriate care. Yes, how prepared are we, bearing in mind the first wave versus the second wave? What lessons did we learn, and how ready are we in terms of handling this wave and offering quite of care services to our clients? Thank you for the wonderful question. Yes, in the very first wave, we quickly established through guidance from the Ministry of Health and partners, especially World Health Organization, UNFPA, IDI. These all came and tried to evaluate what we could offer, bearing in mind the structure of Kawempe National Hospital amidst the services that we offer. And they had advised that since we are quite a very small unit and requiring that we have probably space to have these patients managed, that's proposed a tent at the compound, of which this is going to happen very soon. But in the first wave, we would already just hold up. It was a hold-up center. And then our idea is supposed to take samples and test And once we would find out that this is a positive client, we then safely move them to the designated treatment centers. That time, it was mainly Entebbe Regional Hospital, but with time, we also worked with the Mulago Specialized National Hospital to manage these clients. That's what we did mainly in the first wave. Second wave, a tent is coming. As we brainstormed and discussed with the Minister of Health and the management of Mulago Specialized National Hospital, we were asked that we should actually be given a wing, 5A. And most of these clients are starting June, even much earlier. And I'm glad most of us, myself and Dr. Senior Consultant, my teacher, Dr. Emerida, have been managing these patients, plus a couple of other obstetricians, some of the other residents in the other disciplines, to try and see that we give optimum care to our clients. So we have been picking out these clients through the processes of evaluation, testing them, and then moving them safely to Mulago via 1A, and then they get admitted to level 5A. And once they require any form of intervention, surgical interventions, we've had levels 6 and 5 at the Mulago Specialized Women and Neonatal Hospital, where surgeries are performed, and then recoveries, and see these mothers probably recover and even get discharged. In regards to numbers, I hadn't prepared these. Probably the commissioner will come in to answer. What did we see? Probably could give us a small bit, because we have had this bit of evaluation with the ministry. For the first 8 months, probably about from April, if you add 8 months, we had only 2 maternal deaths, those that are tested positive within the institution. So that is Kawempe National Hospital. These came in, we quickly tested them, and they found them positive, and unfortunately they died of complications of COVID. Those that we have collaborated with our colleagues in Entebbe, only 3 are in the first wave. This second one, most of the data is with the Mulago Specialized National Hospital, because when we would get them in severe condition, we would quickly start on the therapy of oxygen. By that time, we had developments with the antigen tests that are quite rapid. You quickly test, and also having worked with the Minister of Health to develop a test algorithm. So just by looking out and say rapid test is negative does not exclude COVID. Because by the time these patients are presenting, they will probably have presented when the disease is way beyond even the lung stage and probably within the blood system and causing organ failure. So we instituted other systems, pick up PCR, but the PCR turnaround time may be longer. So we have a CT scan with us, free of charge, that we have subjected these clients quickly. We pick the CT scan images and then quickly consult with our colleagues online, and then quickly move these patients to Mulago for proper management. Within the Kawempe, there's been a second oxygen plant that is being placed to improve on the oxygen supply for especially the hold-up area. The IC has been put in place. It's now functional with 2 anesthesiologists. We thank the Minister of Health's effort to try and ensure that we also have some bit of readiness to handle some of these clients, not just moving them before the other centers, the other places prepared. If you remember what happened in May and June, where most of these centers would call and say, we need to move a client. And all you would hear is that we are quite full, we can't do we can't help you out. So thank God that Kawempe is now functional in terms of oxygen and some of the other quick, the emergency medicines that are required to try and save these lives. So I think those are some of my questions that were fired away. Thank you very much for listening.
Thank you so much, Dr. Kazibwe. He has made my work much, much simpler. He has answered quite a number of questions. Some of the questions will be answered by my team members here. We are here as a team. I want to begin with Solomon's question, Solomon from Power FM, regarding our progress in achieving the SDG that's related to maternal and child health. You're aware, it's true, Uganda is a signatory to a number of international protocols, including the SDGs, Sustainable Development Goals, and specifically SDG 3 that is concerned with maternal and child health. On maternal health, we currently stand, the data we had in 2016 was showing that we have 336 per 100,000 maternal deaths. That is the last time we did the demographic health survey. And our target is by 2030 to be 70 or below per 100,000. There is great progress, and that's a very positive comment. There is progress in terms of reducing maternal mortality. We have a better system now. We are able to capture maternal death, investigate them or audit them, what is killing our mothers, where are they dying from, and also institute remedial, or what we call the response. This system is called MPDSR, Maternal and Perinatal Death Surveillance and Review. We are strengthening so much on the response arm because we need to fix the gaps that are within our institutions. This is not a policing intervention, but it's an intervention intended to improve, close the gaps to ensure that mothers do not die of, mothers and newborns are not dying from preventable causes. So the progress has further been enriched by our capacity. I want to assure you that the health system, despite the COVID, with the investment the country has made during the COVID time, we have a stronger health system than ever before. We have an ambulance network. We have ICUs that are soon getting fully functional. We are increasing on the number of human resources. I'm more than optimistic that if COVID went down, the health system will remain stronger than it was before. We have also upgraded health centers, more than 300 health centers tools, which we are not delivering. In my opening remarks, I did mention that our mandate is to make sure that a pregnant mother can be able to access delivery or antenatal services at a small distance. And we've been, as the Ministry of Health, we've been on a program of upgrading the health center 2s to health center 3s and equipping them and resourcing them with human resource. So the 300 health facilities that have been upgraded in the last 3 years have equipment, are delivering, have the human resource. And what we have seen in our data is that the number of deliveries that most people used to deliver from health facilities, right now the number one place for delivery in the country is actually at a health center 3. We have more than around 45% of all women delivering from a health center 3. And this is very commendable. We don't want women. It partly answers someone's question of how are we reducing the cost. If the mother is not going to walk or to travel a long distance to go and deliver, delivering from a nearby place, free of charge, all these services at health center 3s are free of charge. And for some of you who have really moved out in the rural areas, you'll see these are state-of-the-art infrastructure with very good infrastructure for our mothers. Yes, there are still challenges, but we are improving on that. So statistically, we may not tell you where we are from 336 towards 70, but there is commendable progress, and this is 2021. The 70 is for 2030. The measurement will be done in around 2030. We hope a lot more will improve with the interventions, implementation of the high-impact interventions. High-impact interventions, which at technical level, we are emphasizing. These are a set or a package of interventions that are administered in service delivery points to ensure that the safety of mothers, the quality of care has been improved, and the safety of mothers and their pregnancy outcomes is guaranteed. So we think as we continue to do so much into this area, to invest so much in the quality of care, to invest so much in addressing the delays, and that's why we call upon our politicians and the other stakeholders. There is a cardinal delay of delaying to make a decision. This is not within our control as the healthcare system. Someone delays at home and presents when it's late. It has been a very big cause of death. The media can be very good at doing this, sensitizing the people to come to hospital early because the services are available. Dr. Kaziwe has elaborated told us. Our biggest problem where we have minimal control is people delaying at home. Mothers, even men are the commonest culprits because they think they are strong enough when they are sick. So I think those are areas that we need to improve in as we move towards achieving our SDG 3. Uganda didn't achieve the MDG, not so Olive, but we were very close. We did achieve one of infant mortality and child mortality, but on maternal mortality, we are very close, and I think with the current interventions, if we continue at the current pace, we shall be able to do better. The other question was on the cost. On the cost, it's partly answered by my submission, that as long as we have the necessary service packages closer to the people, and we want to emphasize to create an awareness that the healthcare service, the public healthcare services are actually good and cheap. I like the comment from the one honorable, though he was being crucified, that he was praising government facilities. So I think his comment was actually right. We still have challenges in the public facilities, but the cost in public facilities is low. The cost is low or zero. Well, there can never be something that is zero because you have to transport yourself and you have to feed yourself in some instances. So the cesarean section you would get in Mulago or in Kawempe, you are paying for it 3 million. So for young people, I would encourage, some of these services are very good in our public health facilities. So, and it's true, you pay through the nose when you go to the private healthcare facilities. So there is a team that is working on price regulation. It was beginning with the COVID, how COVID people were paying too much. So there is a team at Ministry of Health that's specifically working with the private sector to look at the pricing and price regulation in the private sector. I hope this will come up with a very good strategy. Of course, with our other initiatives of microinsurance schemes, they are in communities. All those are modalities that can reduce the cost on the individual. The National Insurance Health Scheme has not taken off, so we cannot talk much about it, but we think the other microinsurance schemes that exist at community and family level can also help. Incorporating mental health, I've agreed with Dr. Olive, he should talk about it, but the approach we are using as Ministry of Health is integration of all services. So Dr. Olive will just highlight a little more on that. Jingo Francis wanted explicit data on how many have been saved, how many have died. Of course, this information is available. I may not have the exact figures now. I have the broader picture, but this information is available. What I can give is, during our weekly updates, cumulatively from January to date, we have lost around 830 mothers. 830 mothers cumulatively from January to date. These are not mothers who died of COVID. And I want to underline that because the next thing will be in the papers. Dr. Mugai says 830 mothers died of COVID. So cumulatively, that's the number of mothers of maternal deaths that have been reported in our systems that have died due to pregnancy-related complications. But what I want to tell you is that as we review, I have been looking at the data. Between 2 to 5% of these deaths are COVID-related. As Dr. Kaziwe mentioned, the diagnosis of COVID, sometimes it is made much later, either basing on, but if someone presents with COVID-like symptoms, a pregnant mother presents with COVID-like symptoms, difficulty in breathing, desaturating, and the PCR test may actually be negative. But she had an infection that turned negative, but finally she dies of COVID-like complications. So between 2 to 5% of these deaths are actually COVID-related complications. So that one, we can get the figures, but it's good to use the proportions. And that translates to roughly around 20 to 40 of the mothers who died. So we lost mothers due to COVID, pregnant mothers, and that has since changed. The trend is coming down, and because of improved facilities, we have now adequate oxygen for mothers. We did advocate for that. They need a lot of oxygen when they get COVID, and of course, so many were saved. So many were saved. We really mind so much about those who died and what we can learn from them. Our focus is really so on that. So Dr. Kazibu has answered the other questions. And the last one is from this friend of mine from Makabozi. Together with you, I also want to congratulate His Royal Majesty, the Kabaka, upon his 28th coronation anniversary. I also want to congratulate Her Royal Highness, the Queen of Buganda. We are very closely attached with her because of her role in the Kisagati program, which we appreciate so much as Minister of Health. Her Royal Highness, the Kisagati program for the young ladies is one of the methods, the best practices for addressing teenage pregnancy, and we want to appreciate that. Safe home-based care. There's a very clear guideline now, and it's being safe home-based care. Protocols are available. I think what we shall do, my friend from Makaboza will share with you these protocols. It's a very organized system that's now being managed at district level. The districts are managing home-based care. It is for everyone, men, women, pregnant, the elderly, as long as you are infected with COVID-19 and you do not have comorbidities, your blood oxygen levels are still high, you are encouraged to stay at home, manage yourself from home, you are given enough guidelines. There is a team of our village health workers who will monitor you from home. They tell you what to do until you're discharged from that system, even a clear referral system. This has saved our health system a lot, and we think it is growing stronger and stronger, and even as we go through this wave. So I want to appreciate everyone. I think I've been able to answer some questions. Why are we failing to implement the good practices? Very hard question, but any of our colleagues here can answer. We have very good policies, but implementation is poor. It's a whole spectrum. Sometimes you have policies that are not well funded. I think our Honorable Member of Parliament, who also doubled to be a service provider, now she understands she's at the level of giving money as Parliament. Before, she was at the level of providing a service. For us as healthcare workers, we are going to use what government provides us. If they provide us half the budget, we shall use that to provide the service. So I think implementation is majorly affected by bottlenecks in financing, issues around the right people, the right infrastructure, and the right inputs. So I want to thank you so much.
Thank you.
Thank you.
Thank you very much. For the interest of time, I'll request to start with the Honorable MP. You'll give comments on some of the questions. Major questions were for Dr. Richard and Dr. Lawrence. I'll start with the Honorable MP. Give some comments on maybe any question that you'd like to shed light and your parting shots. Let's do parting shots. Dr. Richard referred some questions to Dr. Deo and Dr. Olive. You answer the questions, and as you give your parting shots, so as we can be able to conclude this discussion. Honorable MP. Honorable Sylvia Tumwekwase. I'll give it 1 minute to each.
1 minute. Thank you very much, moderator. I did not have any specific question directed to me, but one of the media people here commented on my submission, especially on the ratio of health workers, different professionals to patients, where I presented on nurse-patient ratio, also doctor-patient ratio. I did not come up with also a very key important professional, the laboratory personnel, which is very key, especially in this COVID era. But all I have to say is that currently, our country is trying to recruit some health workers. I think even right now as we talk, there is ongoing recruitment by the Health Service Commission. So like we said, our health system in the country is significantly improving step by step, and we shall get there. But we still have to advocate for recruitment of also lower facilities, because they are recruiting for national referral hospitals and regional referral hospitals. And remember, like we have just heard in our discussions, that 48% of deliveries take place in health center 3s. And this is where we find most midwives working under a lot of workload pressure. And someone was also asking why there was no any budget allocated to maternal, neonatal, and child health services during this COVID era. So we have to commit our advocacy as parliamentarians that even these lower health center levels, general hospitals, center 4s, and center 3s, need to have a budget for more recruitment of human resources for health, because this is where patients go into first contact with health workers before they are referred to higher level of care. Basically, that is that. And for us, as long as the Ministry of Health, Commissioner, sir, as long as you use us, we shall champion this agenda in Parliament. I thank you.
Thank you very much. Dr. Deo Munube.
Thank you very much. And my parting shot is really to emphasize the importance of home-based care of the children. As been mentioned by the Commissioner, we do also have guidelines as the Uganda Pediatric Association, and I'll be able to share with the moderator, to share with all the media houses. I would just like to emphasize the importance of breastfeeding. We have talked about the mothers who may deliver children and who may get infected with COVID. But breastfeeding is very key to allowing a normal growth in our babies. So please, if you're a mother who delivers a child, you mask, you hand wash, and you continue breastfeeding. The world today, on the 31st of July, begins what we have the World Breastfeeding Week. For the rest of this week, there will be some media engagement to emphasize the importance of breastfeeding. Thank you very much.
Thank you, Doctor. Dr. Olive, they forwarded some questions for you to respond to. I'll give you 2 minutes. 1 minute for your parting shot and 1 minute to respond to that question.
Thank you very much, moderator. The mental health issue in the total response of COVID is an issue of concern, an increasing concern worldwide. And of course, there is a realization that each of us, even us who are here, we have been affected in one way or another, so nobody has been exempted. And therefore, there are increasing guidance on how to incorporate mental health and psychosocial support into all the guidelines that are being developed right now, and ensure that the health worker, even before, especially in maternal health, is able to increasingly communicate, counsel, and find out which mother is having what. So the deeper now we go into counseling and talking to mothers, communicating, trying to find out what they are on a daily basis when we are with them, the more chances that we shall pick. But definite management guidelines at different levels are being incorporated within the national guidance for continuity of essential services within the COVID era in all the levels of care, according to who needs what, right from the community-based. So more investment has been thought through, and there's advocacy to increase the level of investment, even beginning at the level of the village, where parasocials and counselors can be used, and NGOs who are already working there, to incorporate this care within the work that is being done. Lastly, I would really want to say, because a colleague has asked a very important question, so much being said on adolescent pregnancy, but what next? I think very important for all of us to think through is that the pregnancy actually comes from two colleagues. And we remain a lot silent on the male factor. And we must now bring it on the table. We must begin to have new values as a people, and therefore the whole structure of male involvement, male engagement, and men saying no to sex with adolescents. Because that's a major behavioral attitude and practice issue, which we as a community have to incorporate, and we begin to talk about it. The young girls can be given so much education according to their age-appropriate information in regard to sexuality, but really you have to address the other side. Uganda already has actually laws around this area. Sex with a person under 18 is already a crime. But what are those bottlenecks that prevent us as a community to talk about this regularly and go ahead and provide the service within the different sectors, the police, the lawyers, the community? And we hope that investing in a girl child, we shall prevent the adolescent pregnancy, which is the result of two people. And we constantly keep quiet about the male factor. The design must now focus on the actual cause of the problem and what values do we have as a community, and therefore how can we address it in its totality. As we continue to live, to ensure that the girls are empowered with life skills, to say no to a dangerous touch, to say no to gifts which are dangerous, you really can't invest only in the girl child.
Okay, as you conclude, Doctor.
Thank you very much.
Dr. Richard, your parting shots before we go to...
Oh, thank you so much, moderator. I think it's been a very interactive session. We want to appreciate Waweze for according us this opportunity, our media fraternity. We are sending you out today as ambassadors. I have a few questions. I'll share my line. Shall be able to share some of the detailed information that we've not been able to share. And as all my colleagues mentioned here, we are also on a learning trajectory. There's a lot of information that keeps coming out. Most of the people on the left are actually my teachers. They are still in teaching. We are doing a lot of research. So there's a lot of information that keeps coming out. We are on a learning trajectory. We shall keep updating the public on every current information that comes out. We have mentioned that pregnant women, it is safe to have immunization or vaccination in the second and the third trimester. We are trying to look for evidence if first trimester, some countries are even doing first trimester, but for us we are saying second and third. When the vaccine come in, because if you're pregnant, please, the complications of COVID are very serious for pregnant women. Please get vaccinated. We are also very cognizant that we can reduce these costs, and please continue the media supporting the health workers. A message of appreciation from you, the health our colleagues in the media fraternity is very important. It keeps them going. It's a very tough time, especially the ones involved in maternal and child health. The numbers are big. They have not dropped any numbers. As I mentioned in my opening remarks, the number of women delivering in institutions has not dropped. The number of women attending antenatal services has not dropped. So we are looking forward that these people have done a tremendous job, and we need to thank them so much. Thank you, and have a great day.
Thank you very much, Dr. Emerita. I give you 2 minutes. You might have some comments to make. You had not addressed some of them. 2 minutes to address, then your parting shot.
Thank you so much once again to Tawesa and our ministry and the rest of the panelists. All I want to remind our people and the media and the people in virtual communication is that remind us all that although COVID-19 is present and it has caused a lot of fear and scare because of the way it has presented, let's not forget that other conditions which were killing mothers before COVID have not gone away even with COVID. So we need to ensure that we put in extra effort to deal with a reduction of the transmission so that we can go back to work and put in a lot of effort to work. And we need more community engagement, more community involvement regarding reduction of mortality for both the mothers and the newborn. We need to be accountable and especially getting more involved when this person is pregnant. To what extent do we own those mothers? Quite often when there is a death, we are all alarmed and we gather. Let's own this pregnant woman right from the community. Find out if this pregnant woman, the good thing, God made it in such a way that pregnancy as it progresses, it shows. Let's own that pregnant mother. Are you attending antenatal? Ask the people concerned. Where is she going to deliver from? In case there is an emergency, who is going to transport that mother to the next level of care? Is she attending antenatal? All those issues. And then in the event of a bad outcome, let's find out what could have contributed to the death. The colleagues have talked about the issue of MPDSR. As a Thrive researcher, I'm also trying to find out what is it that we can do to make a contribution to reduction of both our deaths of our mothers and the newborns. So let's get involved right from the community, not to wait for the bad outcomes to gather, but let's be involved. Is this woman attending antenatal? Where is she going to deliver from? Who is going to take her to the hospital in case of an emergency? Because community involvement and engagement is powerful. If we are all committed to help our mothers, it will be great. One of the challenges we are facing is the availability of blood products. The schools are now locked down. But when they invite us to donate blood, how many of us go up there freely to donate blood? A man and a woman who are healthy can be able to donate blood at least even up to 3 times. How many of us have kept safe and can donate that blood? Because they've already mentioned the major killer of our mothers is excessive bleeding after delivery. But there are times when we look for that blood and it's not available. So media engage people, and we say that we all need to be involved to ensure that we deal with the issues of delay one, that is delay at individual level and delays at community, so that we advise the mothers to go to the right place. We ensure we mobilize ourselves to avail transport in case ambulances are not available. Those who are doing it very good, so that we get these women to the rightful places early enough. And then we take to task our parliamentarians, our government, to ensure that the environment, our health facilities, the emergency supplies are available, the emergency readiness. We need to have the emergency readiness at all levels. The other thing, the readiness at the family level, the finances. You know, there are quite a number. You remember the health budget. According to the international guidance, it's supposed to be at least 15%. Yes, our government is trying, but I've really reached the 15% commitment to the health budget to ensure that we really see that there is an environment which is conducive to work and ensure that the emergency supplies are available. And again, let's not forget that other causes of death, women are still dying from complications related to unsafe abortions. Encourage our community members to fight the stigma. In case of an unwanted pregnancy, let's support them. Let's bring them to the facilities for care And in case such an event occurs, that you get to know that this person is suffering from unsafe abortion complications, get them to the hospital so that they can be catered for. But advocate for the use of family planning appropriately. And they go in, and the men, I think one of my colleagues has emphasized, the issue of male involvement is critical, because when the men support, it takes two to tango to get a pregnancy. When the men support and we all work together and we ensure timely access, I believe we can make a difference. COVID is worrying and scaring, but what I'm putting forward is that let's remember that the other conditions that used to kill mothers are still with us, and we need to work together and communities and own our mothers, right, to take them through that journey. I believe that we'll have a better outcome. Okay. Thank you so much to the organizers for this kind of community engagement. Okay. I thank you.
Thank you very much, Dr. Emerita. Dr. Lawrence, your parting shot.
Thank you very much, organizers, and this opportunity. A lot has been said, but I'll package my parting shots in 3 areas. The first one is on to thank the government and the able leadership of His Excellency, the President of Uganda, who has believed in the science to try and curb the numbers of COVID infections and mortality. We thank him for that. Then the technocrats at all levels, different ministries, but mainly my line ministry, where they're taking advice from the CDC, IDI, and several other partners to try and advise the president and ask the health workers to see to it that if we adhered to laid down SOPs, adhere to advice from the different perspective, especially trying to see that each and every, or at least we get half of our population vaccinated, and the effort towards this is achieved to try and see that herd immunity comes in so that people can return to the normalcy of their working and trying to survive and boosting the economy. The second one is in line with the focus currently, that it is towards the health workers and health systems. A lot through the partnership that we've had, we are making our lives a little easier, that the PPEs are now currently provided to protect the health workers, but also the public at large. So we thank this, the able leadership at the ministry and the technocrats that are making this possible. The last one is to that health worker, especially the midwives at Center 3s and the very busy Center 2s. Colleagues, visit these places. You may just be seeing pseudo images, probably when you're dealing with general hospitals and regional hospitals, but go down and see what these health Center 2s are doing. You find one woman like this, 2 women, attending to a huge number of natal care and natal mothers coming for natal care, and they probably even conducting deliveries during their shifts. So we wish to thank these people, and we pray that the Lord, as we are hearing that there is a lot of enhancement coming, as we hear them ask for their what is due, an allowance increment, that they should be considered here to appreciate their effort as they, sorry to say, break their backs at the front line. They are doing this with a lot of joy and saving a lot of lives for the Ugandans. Thank you very much for this organization.
Thank you very much, Dr. Lawrence Kaziwe. At this time, we've come to the end, but I have no powers to cross. I will be able to welcome Violet Alinda of Twaweza. She's going to appear via Zoom to close this session. But before she does, allow me to appreciate the panelists. Thank you for sparing your time, sparing your weekend to come and speak to the nation about this. To our audience online, thank you very much for being part of this discussion, for asking important questions and participating in this discussion. Let us keep this discussion flowing online. There are online facilities available to us so as we can continue our discussion online. To the Media Challenge Initiative, thank you very much for also being able to make sure this happens. Martha, I can't thank you enough. Thank you for being there to organize this. as well. I also join the rest of the community and Uganda at large to wish our Kawaka a happy 28th coronation anniversary, and we wish him good health as we strive to live. At this time, allow me to welcome Violet Alinda of Twaweza to give her closing remarks. Thank you very much.
Thanks so much, Mr. Moderator. Just first to say, to register my apologies, I joined in a little late. I was having another engagement. And I'm unable to turn on my camera because I'm using my phone. Really, the message from the Twaweza family is a message of thank you to our panelists. I'll not mention the names. To the journalists that have been in the role from the time we started, which is 6 weeks ago, to the medical professionals that have been joining online, for giving us your time, sharing with us the experiences, but also giving us the knowledge that we needed so much and that we continue to need in this period. We continue to fight the pandemic. We really, really appreciate those efforts, but also most importantly, we want to thank the partnership, especially with the Ministry of Health, that have worked.
Recording in progress.
We really thank you and ask you to continue sharing the information that we have been, especially the correct information, so that we can continue enabling people to have the right information all the time and continue spreading the messages of hope. Thank you so much. I would like to wish you all a great afternoon. Back to you, moderator.
Thank you very much. It's been a journey that we've moved with Twaweza as Ministry of Health. And thank you very much, Twaweza. We look forward for more and more partnerships to make sure that we make our public aware of what we provide. At this time, to our panelists and the people inside here, I've been informed today is Martha's birthday. Happy birthday, Martha. And where is the choir leader? Happy birthday, dear Martha. Happy birthday to you. Happy birthday to you. Happy birthday, dear Martha. Happy birthday, dear. Martha has been